Welcome everyone, especially the fellows. This is the Fellows Course Day. I'll try to give really a brief run through on the role of OCT in current practice. So in 2015, this is where I see the application of OCT in our current cath labs for practical purposes. We can use it for plaque lesion characterization, to look at non-atherosclerotic coronary problems, and of course primarily in the context of PCI, to guide PCI, look at the immediate and late consequences of PCI. And it's up to a few years ago, I would say, ultrasound was the established standard, and I've said was, because in my opinion, I think OCT has taken over that role. And now there are several studies which show the technical superiority of OCT as an imaging tool, really in managing all of these scenarios in the cath lab. So OCT specification-wise is really ideally suited for intracoronary imaging. It's got 10 times the resolution of IVUS. It is very fast at 180 frames per second, which gives you a very detailed view of the entire length of the vessel, and it's also a very fast pullback, up to 40 times the speed of IVUS. So this is a 75 millimeter pullback of IVUS and OCT, and in the time it takes to do this OCT pullback, that's all the IVUS you're going to see. So it's actually very user-friendly in the cath lab, which is why I think it's being taken up so avidly in most labs where it is present. In addition, the scan area, which used to be an issue with IVUS, OCT, is now really, in all practical terms, I can image a vessel up to 6 millimeters in diameter without any issues. A depth of penetration, really in our clinical practice, we really don't want to know what plaque volume is or what remodeling index is for day-to-day clinical practice. So depth of penetration in that context is not an issue. And with the current very rapid, fast-acquiring OCT systems, blood clearing with either contrast or a combination of contrast and ringers really does not cause any limitations. From the point of view of plaque characterization, it's as clear as day. I think the resolution of OCT clearly shows the absolute superiority in looking at the plaque characteristics compared to intravascular ultrasound. And as Vijay mentioned, in the context of stenting and sizing the vessel, it's all about the lumen. And we also now know that quantitative measurements of OCT are extremely accurate and in fact are closest to the truth of the actual dimension, and this is with phantoms, so that in reality IVUS actually overestimates lumens a little bit. And we also have, and I won't go through these in the interest of time, but multiple studies looking at OCT and IVUS and angiography in looking at the immediate consequences of stenting, dissections, thrombus, tissue prolapse, all showing really the superiority of OCT with its resolution in detecting all these changes. Can we play these things? Oh, there it goes. So the other advantage is that we've got a very high volume data set, so 3D rendering, including now real-time 3D rendering, is possible. And certainly there's a big interest, particularly in Japan, in Europe, in looking at this for bifurcation stenting. So let's start with culprit plaque and lesion characterization. Where would I use this? Well, it's just where there's a clinical need, where angiography is ambiguous, or I want a little bit more information. So where is the culprit lesion? Is there a culprit lesion at all? It could have been an embolus from atrial fibrillation, perhaps. What is the nature of the lesion? Do I need to stent it? You may have angiographically 2 or 3 lesions in an ACS. So which is the culprit lesion I need to treat? And this is most relevant in ACS, and we've got old Vanquish data, in fact, which shows that up to 40% of cases in ACS did not have an identifiable angiographic culprit. So here's an example. 38-year-old male, smoker, non-STEMI with a troponin rise. And that's his angiogram. It showed a 70 to 80% mid-RCA lesion with a bit of haziness. Now, we didn't stent him straight up because he'd come from an outside hospital and he was severely anemic. So we kept him in, sorted out his GI issues, make sure he was stable, and brought him in again in a few days' time with a view to stenting. So we put a guide catheter in, gave some GTN, and started to take some setup shots, and that's what we got. Actually, not a lot. And there's a little bit of tapering there. You might just see where the lesion was. So my fellow said, look, it's spasm. Let's send him home with some antispasmodics and do the next case. But, well, let's do an OCT and see what we see. And this is the OCT. Unfortunately, I can't control it from here. But you might see at the OCT down here, you see something really which reflected where that spasm was. And this is what we saw. In fact, there is a thrombotic lesion with some eccentric plaque, which was a fibroatheroma, and this is a typical appearance of what plaque erosion is like. So this OCT actually made a clear diagnostic decision. It wasn't spasm, it was actually an ACS with plaque disruption due to plaque erosion, with a secondary spasm because of all the vasoactive issues. So the treatment for him wasn't verapamil, but it was ACS treatment, dual antiplatelet therapy and secondary prevention therapies. We didn't stent him. Another case, what is the culprit? A 40-year-old anterior STEMI with successful lysis who was transferred from an outside hospital about 3 or 4 days later for angiography. This is what the angiogram showed, at least a moderate lesion in the LAD just at and distal to the bifurcation of a very large diagonal. So we did an OCT on him, and again a very similar scenario. That's the left main, and you can see the left main really well, circumflex, that's that large first diagonal. And there's the plaque in the first diagonal, which again you can see a bit of thrombus and shadowing from the thrombus, and a fibroatheroma. And this is again typical for plaque erosion. We did an FFR on him, and the FFR was almost 0.9. So in the context of an ACS where you have an FFR which is not in the borderline region, it is actually diagnostic. And in this patient, we did an index of microvascular resistance, which was also normal. So our FFR really was very valid in this context. And we corroborated that with an area from OCT, which was almost full. And in him, we gave him medical therapy alone. And this sort of strategy is now coming out in the literature as probably a good strategy to use in these patients. And this is from Prati's group in Italy, who looked at patients with STEMI, who they aspirated thrombus from. And on OCT, if they didn't have occlusive plaque, and they had a plaque which didn't have plaque rupture, usually indicating it's likely to be plaque erosion, they treated these people medically. And at follow-up at over 700 days, they're doing well. And there's currently looking at a randomized trial for this. What about non-atherosclerotic coronary problems? This is a 46-year-old female presented with an anterior STEMI and occluded ratty-looking LAD, occluded just after the first septal. And that's what the OCT showed, a beautiful picture of spontaneous coronary artery dissection with hematoma near the proximal end. Very nice hematoma from the dissection, a little proximal flap. And just proximal to that, you can see actually where contrast has leaked in to that space and usually causes staining on the vessel. So nice, unambiguous pictures to make a diagnosis of SCAD. And in fact, that's the LAD coming into the circumflex and left main. And that's the left main. Then we go to OCT in our current practice in the context of PCI, and this is where I suppose there is most interest. And basically we do this really to prevent stent failure, thrombosis and restenosis by assessing the lesion, look at the stenting strategy, optimum lesion preparation, device sizing, really to maximize benefit and minimize complications, and of course to guide complex lesions. We can also look at the immediate consequences of PCI, undersizing, malapposition, dissections, thrombus, those little hazy shadows, all really to prevent this. And of course, once this happens, we can use intravascular imaging to try and treat it. The next question is, where do we use this? Do we use it as an ad hoc clinical tool when we need it? So on an angiogram, there may be a lesion which is difficult to figure out because of overlap, how long it is or the diameters, and you would use intravascular imaging to gauge that. Or after a stent, you might have some angiographic ambiguity saying, is this a thrombus or is there a dissection? And you might use imaging to solve that clinical problem. In that context, you don't need data. But if you're using it for routine use in PCI, so every case gets intravascular imaging, that increases the cost to your lab exponentially. So you really need data to say that a routine use will improve outcomes. It's about balancing cost and benefit. Now, do we have that sort of data? Well, most of the data is from IVUS. And I suppose we can correlate that because they are imaging tools. A lot of the data are observational studies of associations and causality. And you can see the vast number of these studies, both with IVUS and to a lesser extent with OCT, showing that geographic miss will have bad outcomes or malapposition may have bad outcomes. But really the data we want is imaging-guided PCI studies where up front you do imaging and see if that makes a difference. And again, most of them are observational, few are randomized. And just as a summing up, I'll take you to this meta-analysis by Zhang, which suggests that in the overall population, there is a benefit in using routine intravascular imaging in the context of PCI by reducing MACE. But if you tease out the details and just look at the 3 randomized studies, that is not significant. And that is the case for all the other endpoints from these meta-analyses. Stent thrombosis, similar. All-cause mortality, myocardial infarction, target vessel revascularization. And what that tells me is, yeah, there certainly seems to be a trend that it is beneficial, but no randomized data. One study only from OCT, again from Prati's group, where they looked at OCT-guided PCI versus angio-guided PCI. They were randomly matched and suggested there was some benefit with cardiac death and MACE. But again, it's non-randomized, retrospective, and there are problems with the design of the study which comes out in the results. All of these hypothesis generating, but I don't think anything that should change our practice. So in conclusion, with regards PCI, I don't think you can justify using OCT or IVUS routinely for every single PCI. I don't think we have good data to support that. But for ad hoc use, where there's a clinical need, most certainly. So in the context of guiding PCI, where would I use it in our lab? Well, stent sizing, stenting strategy, where angiography does not provide adequate information. Very similar to IVUS, diffuse disease, vessel overlap, flow images. If it's a complex PCI, and the data would suggest the more complex the PCI, the more benefit you get from imaging, bifurcations, for example, or if you have an important location like the left main. And OCT can be used for most left mains, the vast majority of left main interventions. What about the immediate consequences of PCI? You put a stent in, and here angiography is ambiguous. Either there's a hazy shadow or a filling defect, and you want to know what that is, or is unlikely to show anything, and you're worried that you may have undersized the stent or there's malapposition. This is a case of one of those hazy shadows. As an ACS, treated with a stent in the proximal LAD, but on angiography, there was an impression that there was some linear haziness there, and we weren't sure whether that was real or whether it was due to sort of a radiographic overlap. So we did an OCT, and this is what we showed. This is the proximal end of that stent, which starts there, going proximally towards the left main. You can see there's starting to show a lipid-rich plaque with thinning of the cap on the shoulder there. It gets a bit thinner, a little bit thinner, and something's happening there. There's a bit of disruption. Now you're seeing a bit of thrombus and some disruption, and there's thrombus there. So this is a clear case of geographic miss. We stented the lesion where it looked the severest, but as autopsy studies have consistently shown us, sometimes the actual culprit is a lot more proximal. And this is where OCT helped. Stent malapposition. This is a case of an RCA where we stented into a slightly ectatic segment. Because we wanted to stop antiplatelet therapy in 6 weeks for an operation, we just wanted to make sure everything was well opposed there, and geographically it looked okay. OCT clearly shows malapposition. You can't see it in IVUS here, but really here there's no ambiguity at all. What about the late consequences of PCI, the things we want to prevent, restenosis and stent thrombosis? In restenosis, this is where I think OCT is useful. One, if you want great pictures, you can always do OCT for restenosis because they're fantastic pictures, but you don't do it just for the pictures. If you have recurrent restenosis, it's very important that you make sure there isn't a mechanical issue, because if you don't fix the mechanical issue, they're going to keep coming back. And here OCT is very useful. If there's an unusual restenosis, for example, you don't expect them to come back with restenosis, early DES restenosis. If there's an ACS event, for example, and they only have moderate restenosis in the vessel, you want to look for whether there's any new atherosclerosis or plaque disruption distal to that in-stent restenosis. And sometimes it's actually quite good for guiding POBA with a drug-eluting balloon, or to pick the optimal stent size for bare metal stent restenosis if you're treating it with a drug-eluting stent, particularly if you do not know what the size of the original stent was. Here's an example of one of those unusual restenoses, LAD PCI with the Zions for angina, settled down but recurrent angina at 2 months. He was very compliant with all his treatment. This is the lesion that was treated. That's close PCI, 3.5 up to 3.75, very nice result. Comes back 2 months later, nasty looking lesion. OCT really tells the story. It's very focal, eccentric, and really ugly looking restenosis with a lot of vasovasorum, and likely he had a very bad inflammatory reaction to his drug-eluting stent. Some mild proximal malapposition. So here we just treated him with balloon angioplasty. We didn't want to implant any more drugs in him because he obviously doesn't react well to drugs. And this guy has done well. What about stent thrombosis? Now, stent thrombosis is a real sentinel event. You don't get a second chance. And in my opinion, everyone that comes in with stent thrombosis should be imaged, be it OCT or IVUS, whichever you have in your lab. And this is useful really for a targeted approach to treating stent thrombosis. You know, you could say, well, he's got stent thrombosis, let's just suck the thrombus out, whack in a big DES, put him on triple antiplatelet therapy, and he'll be fine. But that sort of strategy will come back to bite you if in 2 weeks' time he comes back in with a massive GI bleed. And I think OCT is unquestionably superior for this indication and is very safe and would be our go-to imaging modality for this. And these are the mechanical issues we look for when we image people with OCT who come in with stent thrombosis after adequate thrombus aspiration. And these are some of the anatomical issues which are becoming increasingly prevalent: LASMA and new atherosclerosis, particularly for very late stent thrombosis. And there's some good data from histopathology and OCT on this. An example, 38-year-old male, STEMI from an outside hospital. He was treated there with primary PCI with a bare metal stent, 3/10. This is the index case from that hospital. Occluded obtuse marginal, really. Seemed a very satisfactory result post-PCI. 8 days later, he had an out-of-hospital cardiac arrest while sleeping at his home, resuscitated by his wife. He was transferred to our hospital. And that's the angio. It's clearly occluded his stent. And this is the OCT. And this is very instructive. That's the long view, which is also very, very useful. And this shows quite clearly a lot of thrombus and proximally clear malapposition of the stent with the malapposed areas lined with thrombus. And this was clearly the nidus. In addition, you get the impression, looking at the distal and proximal reference segments, that the stent might also be too small. And measuring it, you can clearly see it's a combination of an undersized stent with malapposition. As Vijay said, malapposition alone is rarely causing stent thrombosis. We did a POBA, and he returned with a massive GI bleed 6 weeks later, and so we were very fortunate that we didn't put another stent in. Neoatherosclerosis, also increasingly an issue with stent thrombosis, very easily and nicely seen. This is a prior healed ruptured plaque. You can see little calcified nodules in neoatherosclerosis in there. This is a lipid-rich plaque in neoatherosclerosis through an old GFX stent. So, to end, intravascular imaging, this is the appropriate use criteria from ACC/AHA, absolutely no mention of OCT. The Europeans, a lot better. IVUS used to assess stent failure and in selected patients to optimize stent implantation. This is how I think it should look in 2015. And to conclude, I think it is clearly the investigation modality of choice for ad hoc clinical use in all of these areas. There's no evidence to support its routine use in PCI, and that includes OCT or IVUS. And clearly, hopefully, we will get some proper randomized studies for the first time in intravascular imaging to actually sort this problem out. Thank you.